See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist Shauna Butler.
The majority right now of adults in the United States have one or more chronic conditions. If you project out into the future, it's getting worse. Our life expectancy is going down really since the 1950s. What is also troublesome is that we're seeing similar kinds of chronic conditions in children and adolescents, which are unprecedented and really speak to the disadvantage that we have in our country around promoting health and health promotion. I think every single person in our country is thinking about and asking a tough question. How do we come up with solutions that will really change the policy landscape so that our entire country can have a more healthy, more positive, more optimistic future? And then how do we go about the development of new specific interventions and scaling them up so that we can actually get policymakers, key decision makers, and payers to reimburse for the kinds of innovations that nurses are creating?
Welcome to See You Now. I'm Shauna Butler. The United States is a country known and admired for scientific excellence and innovation, for leading the world in drug development and medical breakthroughs, for world-class and record-breaking athletic performances, for its ambition and its wealth, and for spending much of its wealth on the health care of its citizens. Yet, despite all these impressive accomplishments and investments, and the U.S. being one of the wealthiest nations, it is far from the healthiest nation. Across the lifespan and across every demographic group, on average, Americans are living shorter and sicker lives than their counterparts in other high-income nations. A growing body of research is calling attention to this alarming problem and trend known in research circles as the international mortality gap. And the U.S. health disadvantage can't be attributed solely to the adverse health status of racial or ethnic minorities or to poverty, because recent studies suggest that even highly advantaged Americans may be in worse health than their counterparts in other countries. Increasingly, researchers are examining and pointing to the policies and laws as key differences and drivers in the U.S. life expectancy crisis. Cigarette taxes, seatbelt laws, public health spending, sexual and reproductive health access, air emission and quality standards. Policies on these and so many other issues play a key role in determining the rates of chronic illnesses and causes of death across a wide swath of the U.S. In this episode, we head to the Mecca of the policy world, Washington, D.C., and meet a nurse who is leading a new institute working to redesign the U.S. healthcare system by shifting policy and practice to more preventive, value-based, and whole-person care, and highlighting the essential role nurses play in shaping solutions and policy to improve the health for every community and every citizen.
Hi, I'm Vincent Guilamo-Ramos. I am the Executive Director of the Institute for Policy Solutions at the Johns Hopkins School of Nursing. I also am an Aspen Health Innovators Fellow, and I'm also a graduate of the 2016 class of the Presidential Leadership Scholars Program, and I'm very much honored to serve as the co-chair of the Health and Human Services Presidential Advisory Committee on HIV and AIDS. I am trained as a nurse, in particular as a nurse practitioner who specializes in primary care and psychiatric mental health nursing. One of the things that I love most about the physical location of the new Johns Hopkins University Bloomberg Center at 555 Pennsylvania Avenue is that it just steps from our nation's capital. You can see it from any of the windows. Right across the street is the National Galleries. You can see the National Mall. You can see the National Monument. And one of the things that's beautiful about the interior of the space is that it's very open, it's inviting and welcomes faculty, students, and community into shared spaces where there are many places to convene, to have performances. There's beautiful art on the wall. It's really perfectly situated in terms of proximity to our nation's government and really the helm of where health policy decisions are being made.
It is a truly magnificent space and setting, Vincent. There is an unmistakable energy that's unique to the location. I have such a love affair with Washington, D.C. I grew up there, did a lot of my early training, early practice, and I think of it really as a spiritual home. And I tell people all the time, at some point in your life, you must find a way to live in DC, no matter what it is that you care about, whether it's bricks, bicycles, bugs, balloons, biotech, whatever. You will find people who are expert. You will find centers that are doing all sorts of studies who are advocating. It's just this very rich, vibrant area where people care deeply about things, and they want to tell you about it. They want to bring you in, and they want to convert you to the things that they care about. You're new to the area, exploring. What are you finding as far as the Washington, D.C. area?
So it's interesting because I arrived on January 2nd, and so I'm really new to D.C. I will say that even in that short time, I have noticed a number of things. You definitely meet people who come to D.C. to get something done. They have deep commitments, passions. They're coming to our nation's capital because they care about some aspect of our country's current state or our future state, and they want to make a difference. And I particularly love when I meet people who share my interests around health, but there are all sorts of people that live in D.C. that are working in federal government or are in institutions that surround issues that pertain to policy and to our nation's overall governance and operations.
Well, you are exactly what you just described. You are somebody who is coming to DC because you have things that you want to get done, and you are uniquely prepared and positioned. So I want you to introduce us to the Institute for Policy Solutions at the Johns Hopkins School of Nursing. Share all of the exciting details of what it is, why it is, who it is.
I want to maybe start by answering it by sharing a little bit about my own path to getting here, because I think it's really intertwined with the vision and mission of the Institute. I'm Latino. I grew up in the South Bronx. I have parents who are both immigrants, one from Puerto Rico, one from the Dominican Republic. And I grew up in a neighborhood where almost everybody was Latino or African American. And I didn't realize at the time that there were communities that were not that far from where I lived where life was very, very different. It was amazing in many ways. I had a strong sense of my cultural identity, who I am, my community, strong roots. And I also realized, Shauna, that when I traveled to places like Manhattan, I would sort of look out the window of public school buses and I would say, on the way to that museum trip or wherever we were going, it was typically part of school, that life looked different, that people's experiences, their homes, the streets, the kinds of stores, how they dressed, things just looked different. And I was really
Did they look different, better, or different aspirationally? I mean, different, like.
To be honest, they looked a lot nicer than where I was coming from. And as a child and as a person who was growing up, I wanted to have some of that experience. And I felt perplexed by, well, why didn't things look quite that way in my own neighborhood? And, as I got older, I started to understand that so much of what really shapes what happens to us is the community where we're born, where we live, where we grow up, where we work, and that social conditions play a huge role in our well-being. And so, Shauna, I am a proud nurse today, but I didn't start off as a nurse. I started off as a social worker, working on issues related to why do people fall through certain cracks in our society's fabric and wind up in tough situations? And then how do I prevent, or how do we as a country prevent people from experiencing really difficult circumstances like poverty? That led me to public health, thinking about how communities could come together and we could leverage community solutions that really engage the people that live in a particular geography, a particular neighborhood, and how they could play a role in what happens in their lives. All along the way, I had this nagging feeling that I really wanted to provide direct care. I knew that I was committed to prevention. I was committed to health promotion. And when people do, in fact, get sick or develop a condition, I wanted to help them to get better. And that led to nursing. And for me, what the Institute for Policy Solutions is about is the integration of this deep commitment to social welfare and social justice, to public health and thinking about communities and families and people in broader contexts, and nursing, which brings together whole person-centered care. Those three things are what have led me to this new opportunity that I'm super excited about, and the chance for being able to shape policy and how we create a context where we can improve health for everyone, for every single person and community in our country.
So tell us more about the Bloomberg Center itself. Many people will be familiar with that location. They may know it as the museum. That was a wonderful experience and museum that really was talking about the storytelling and the power of the freedom of the press and how we produce stories, how they get told, journalism. Sadly, it ran into a lot of financial difficulties. But I think what is quite interesting with the location of the Bloomberg Center is that policy and change is driven by people and stories. And so it has this wonderful root and history. So take us on a tour of what that space looks like and who else is there.
It's absolutely a beautiful facility. And I think it makes a statement about Hopkins and really the integration of multiple schools. The Bloomberg Center has numerous schools that are there: public policy, international affairs, nursing, medicine. There's really a collaboration across many of the schools at Hopkins to have a presence in DC. The physical space, it's very open. It invites collaboration. It really speaks to bringing students and faculty and the public and key decision makers into one home to tackle some of the most important issues that we're facing as a nation. For me, Shauna, that primarily focuses on health. And I think the location of being just minutes away from our nation's capital is important. It allows us to keep at the forefront of our work. The government is there. It's visible. It's very present. It also allows us to have great access and proximity if there's a need to meet with someone, to visit an elected official, to have some conversation with a national nonprofit organization or some entity that is leading health redesign in our country. They're there. And I think that it brings together students and faculty who are very curious about how they can, from the vantage point of DC, have positive impacts on the country.
And you have a lot of really interesting neighbors. You're not too far from Health and Human Services. You're not too far from the Centers for Medicaid. And those are our typical partners, government agencies in redesigning health. But as so many of us know, inequities arise not from the 20% of time that people spend in a clinical environment and in our healthcare spaces, but having proximity to the Environmental Protection Agency, having proximity to the Department of Transportation, the Department of Agriculture. When we think about all of the different partners that we need and the relationships that we need to develop, it's going across the sectors. It's going across the agencies and departments. So that location, I think, is critical. So tell us about who is part of the Institute. Why are some of these elements critical to the success of the mission of the Institute?
Sure. I mean, I think you are absolutely correct that in order for us to redesign health, one of the things that I would like to share is really the mission of the Institute for Policy Solutions, which is to redesign health, to move health into much more prevention, much more health promotion. And when people do get sick, really restoring them to their optimal health, the best that they can actually achieve, versus a workforce, any kind of healthcare workforce that is primarily being trained to care for people once they get sick. And so if you think about our country and why this is such an important moment, the fact that the majority right now of adults in the United States have one or more chronic conditions. If you project out into the future what we look like as an overall population, that basic trend is going in the wrong direction. It's getting worse. Our life expectancy is going down. People typically talk about COVID and the opioid epidemic as being major drivers of the reductions in life expectancy. That's true, but actually some really interesting research came out in the American Journal of Public Health not long ago, and I would hope that folks, as they're listening, can really hear the urgency in what I'm trying to communicate. That life expectancy, it didn't just start to go down in the last couple of years because of COVID and the opioid epidemic. Really, since the 1950s, there's been evidence that life expectancy across the globe in many geographies has been going up, and that our life expectancy in the U.S. has been going in the wrong direction. We have been showing, particularly in certain segments of the population, certain geographic spaces, life expectancy, for example, in Mississippi is actually today less than it is in Bangladesh. And that kind of difference, I mean, Shauna, it's not really acceptable for the United States.
It's not. And a phrase that I think we need to be spending a lot of time socializing so that people grasp this is the American mortality crisis, that there is a disadvantage to being an American as far as our longevity. And what a lot of the data demonstrates is that we're living shorter lives. That's the length of life expectancy, but we're living sicker lives. So our health span is decreasing. And you point out, you reference Mississippi, but I think what's really important to note, no matter what state you're in, you will find a pocket where the disparity in life expectancy is dramatic. And it's on a zip code basis difference. These reports have, zeroed in on regions of the country, the Midwest and the southern states. But that's not to say that in Michigan or Maine or California or Massachusetts, where they tend to have, as a state average, a higher life expectancy than the rest of the US. But there are cities and counties and areas within each one of those. So it's quite striking that the fundamental thing that we need to do as a country is to keep people alive. We're not doing as good a job as we have in the past.
I think you're absolutely right. And I think what is also troublesome is that sometimes people will say, Vincent, but that has to do with just getting older. We're seeing similar kinds of chronic conditions in children and adolescents, which are unprecedented and really speak to the disadvantage that we have in our country around promoting health and health promotion.
This is where, when we talk about promotion, why it is so important to be in a place where you can work across agencies, because the health promotion piece requires that we think about transportation. We think about access to the internet. We think about food. We think about housing and making sure that all of those things are secure. Those are our promotion pieces. And I think the reason why you don't hear it in many of these discussions is because the discussions are driven by budgets and by policies. So you do what's within your budget and with what's within your scope. So going back to your mission and your vision, it really is a different reimagination where we're promoting and producing health as opposed to a sickness-based model. Because I think the vast majority of our time and dollars and mind share is spent really late, and it requires us as practitioners and also as policymakers to move further and further upstream and go broadly across sector. That's really where we get to help.
I think, Shana, that you're hitting on all the points that are important to me. They really make a difference for real people. And even more interesting, which is the point I heard you just raising, is that when we look at geographies where there's a lot of economic disadvantage, where there's lack of employment opportunities, where people are struggling with food insecurity, where they may not have transportation. And I wish that more people would see those things as being connected. The outcome with the way that the institutions are organized, the way that the policy is set up to facilitate health or to create some barriers, whether they be unintended or they actually may be pretty intentional in terms of excluding some groups.
So since you brought that up, I think it's a really good place for us to name the headlines that we're seeing. So many of them talk about the experiences, the health disparities, the gaps that we talk about, and they're driven by policies that exist, and they're driven by policies that are absent. I think sometimes people aren't connecting the policies that are in place impact the care that they have access to, or the frustrations that they experience, the things that they don't have access to. So when you think about this list of things that are healthcare impacted and policy driven, why don't you lay that out there? What is that laundry list?
I think, Shona, there's so many. I'll just pick some of the top headliners that I think right now are sort of weighing heavily on me and others in our country. So I think a couple of things stand out. The first is a recent decision by the Supreme Court around the consideration of race in admissions processes in schools and institutions of higher education, colleges and universities. And I think this is a very delicate issue because as a country, we really believe in a fair chance. We think everyone should have a fair chance and that it should be equal in terms of how it is that somebody enters college. The problem with this is that what's invisible is that actually when things are equal, they're not necessarily equitable. It doesn't mean that everybody has a fair chance. And those two words are often used synonymously, but they're not the same thing. They're actually quite different. And one of the challenges that we're not really seeing is that while we may not be able to consider race in admissions decisions, the best evidence that we have from our science is that having a diverse and inclusive workforce, all different kinds of actors who are part of interprofessional teams who bring their lived experiences and their professional training to the delivery of care, that results in the best outcomes. And by limiting our consideration from the policy point of view, in this case, an actual law, legal decision that we have to adhere to, it will make it harder for us to have the kinds of care teams that we know are associated with the best outcomes for the broadest number of people who live in our country and who represent who we are demographically.
Yeah, our care gets better when we're being cared for by people who live like us, pray like us, eat like us, and come from the neighborhoods that we know. I'm in the state of Texas, and there's not a single news program where I don't hear a leading story or an important story that I think there's a health impact here. There's a policy issue here. At the Institute, have you had some of those come across your desk?
I mean, I think there are a couple that we're actually planning to work on and develop further. One of them has to do with the border, and that's sort of near and dear to Texas, and really that we're experiencing very large increases. One could argue that it's a humanitarian crisis along the U.S.-Mexico border with people coming from all over the world. And that increase in migration is presenting a number of challenges. And I won't debate, Shauna, whether or not people should or shouldn't come. What I will say is that as a country, we do need some way of dealing with the fact that people are coming and that we need some solutions that move beyond kind of our current state. We need a more comprehensive solution to dealing with migration. And that means getting really honest about, well, why are people coming? And then also, is there any sort of connection between our needs as a country in terms of a labor workforce and the people who are coming? Because in our history, there has been time when we've had much better policies and programs that have allowed people to come and then to return in ways that were more structured. Some of that has eroded and changed, which has resulted in some of the dynamics that we see today, as well as the conditions in the countries of origin where people are coming from also changing. So migration. I think another hot item, I'm sort of going for the big ones, Shauna, today on our time, the Dobbs decision, and really thinking about accessing the full range of sexual and reproductive health services, everything from abstinence to abortion. Now, while Dobbs deals specifically with abortion, I was very intentional about saying that as healthcare providers, we really want people to have the full range of options, and our focus should be on prevention and health promotion. But when people do experience an outcome that is inconsistent for whatever the reason may be with their choice of what they want to do in their lives, they should be able to access evidence-based healthcare, particularly when we know that it can be safe and that it doesn't necessarily mean that someone is doing something that's wrong. I know that's somewhat controversial, but I want to be really...
No, I was just saying, and I think there are non-controversial parts to all of this, one of which is these decisions have a huge impact on our training. It has a huge impact on the workforce, the availability and the access, and we're seeing that 100% in Texas. Just a report that was released last week that for the first time in 15 years, we've seen an increase in teen pregnancies. So, these policies, they are going to have impacts. They're going to have outcomes, which then drive, where do we get care? Who delivers care? How do we teach the care? How do we train for it? So regardless, it's just whatever the policy is, it has implications for people's health, for the training, for the workforce. And we're seeing that play out rapidly in people's lives and in people's practices.
Absolutely. I mean, you're hitting on so many important issues. As I sit back and think about our country across many areas, whether it be mental health, depression, anxiety, we've talked about migration, we've talked a little bit about sexual and reproductive health, certainly what's happening with syphilis and really the spike in congenital syphilis. And it's very geographically concentrated. 75% of the new syphilis infections are in specific geographies. That tells you that
and they are newborns.
And they're newborns. Context matters. The enduring problem of sexually transmitted infections, and I'm not thinking solely about syphilis, but gonorrhea and chlamydia and other kinds of sexually transmitted infections that have been going up, and at an all-time high. I think that the growing percent of our income being spent on our healthcare needs, because it's getting more and more expensive to buy whatever the medications are, or to see certain kinds of providers, being able to actually identify a specialist if you need a specialist and getting on that appointment list. And I'm being very intentional because it is oftentimes a list and a long delay of getting that appointment that is so important to preserving our health and addressing our concerns. I mean, these are all things, Shawna, that I think every single person in our country is thinking about and asking a tough question. How do we come up with solutions that will really change the policy landscape so that our entire country can have a more healthy, more positive, more optimistic future?
And I'm so glad you're going over into the solutions piece, just to add a couple of topics there that have huge implications in healthcare that are absolutely policy-driven. Data privacy. We're using AIs. We're using remote monitoring. We've got smart devices. So there's a lot of policy going on right now that drives what it is that we're actually able to do with our data. How do we secure it? Who owns it? How do we keep it private? So there are lots and lots of things that are happening in bodies of decision-making and policy levels at a national, a local, an institutional, and industry-based level. And all of these are things that as a center, as an institute that's focused on policy and on solutions, we just have to know that there's this huge landscape that we're working with. So let's turn to solutions, and then we'll get to policy.
So I think before I get into the specific solutions, I think I want to take a step back, Shawna, and say that one of the things about the Institute for Policy Solutions that is so unique and that really makes it different than other kinds of health policy research centers or institutes or initiatives is that it draws upon the wisdom and the experience, the expertise of the nursing workforce. And here's the big and, we are also leaders and we are advocates and we have expertise and we can shape important solutions based on our proximity to people's lives and the kinds of circumstances and conditions that they develop. And Shawna, it's really important to me that we not lead with the nursing part. We lead with redesigning health and that we are committed to improving the health of every single person in our country. It's not about pushing nursing's agenda. It's about pushing our country's health, but recognizing that nurses play an important role and that we need, as a society, to fully embrace the full workforce, including the largest segment, nurses. I want to share with you something, Shawna, that was really perplexing to me. When I started down this path, I knew that there were many interventions, many healthcare models that had been developed by nurses that were not necessarily there wasn't uptake necessarily in society, but the contributions were there. And the evidence for what they were doing was there and what they were intended to do.
Can you name a few of those? while you're talking, these interventions and these models, like what are some that I was thinking of, like the nurse family partnership.
Oh, the nurse family partnership is very famous, but I think also Capable, or I developed one called Families Talking Together. During COVID, there was the nurse community family partnership. I think the best example would be in the American Academy of Nursing. There is on their webpage a program called Edge Runners. Edge Runners are a list of hundreds of nursing interventions that have addressed outcomes that matter, that have reduced cost, and that have had a positive impact on the health of our nation. And the American Academy of Nursing has been really distilling and creating a repository of these programs. But Shauna, nobody really knows outside of nursing that those programs are there. One of the things that I did about a year and a half ago is I started to look at all the nursing interventions in the literature, and I noticed some really interesting similarities. Now, they all dealt with different settings and different populations across the health continuum. So it wasn't just one health condition. There were many different things that the programs were addressing, but they had a set of underlining characteristics that actually made them the nurse-driven solutions that our country needs. First and foremost, they were very much centered on whole person care, not a body part, not a particular illness, but the whole person in context of who they are, their life, their well-being, broadly defined, and also the particular condition that they're experiencing. They were locationally flexible. They didn't only happen at the bedside. They happened in the community through telehealth, home visitation, in schools, in correctional settings. I was amazed at all the places where nurses were showing up and innovating care in ways that they could bring that care to the people that needed it the most. They were heavily focused on clinical expertise. It wasn't just empathy and trust, which are essential. I don't want to minimize those, but they were actual clinical skills, particularly around prevention and health promotion and restorative care, a deep commitment to restoring the health of that individual or that family. They tended to focus on communities and families and not just the person in isolation, the patient. It was this patient in a broader family or community. It really pulled in the resources of what wraps around the fabric of our lives. There was a commitment to strengths and not just the functional impairment or whatever it was that they were experiencing, but how do we build, Sean, on who we each are, and how do we bring that to our well-being? They used data and technology. We were innovators. Those are words that often nurses often don't use in our vocabulary, but we should, because the programs represented a ton of innovation and they were evidence-informed. They brought data to bear. They were culturally appropriate. They were aligned with the communities that they serve. And they were all wrapped around a delivery mechanism that was very much, as I mentioned, whole person and person-centered. These programs, the hundreds of programs that exist that, outside of nursing, few people sort of know about, they actually are the solution to what we need as a country in terms of how we think about healthcare, not in nursing, but across all of healthcare. That's what IPS, the Institute for Policy Solutions here at the Johns Hopkins School of Nursing, is aiming to do. How do we build a new way of thinking about care for every person in our country? And then how do we go about chipping away at the development of new specific interventions and scaling them up so that we can actually get policymakers, key decision makers, and payers to reimburse for the kinds of innovations that nurses are creating. That's the vision, Shauna. That's the way that we want to go. And we actually need help in doing that. We need folks to see the value of what we're trying to accomplish from our nursing-driven perspective.
So you're new in the city. You got to meet your neighbors. You want to make friends and let people know, hey, the Institute's here. We're all about policy and we're all about solutions. And we've got a lot of them that are going to fit into your existing programs and opportunities. We've got what you're looking for. So when you launched and introduced yourself to the different agencies and legislators and policy bodies who are there located in DC, very focused on these same types of issues, what was the reception and what did you learn out of all of this that you thought, wow, That surprises me. What was their feedback? Have you had any adjustments in how you think and talk about this?
So I think the biggest lesson, I'll start with sort of the adjustment, and the thing that was most profound for me is I really immediately bumped into, Shauna, the tension in the health workforce around roles and identities and what I'll call winners and losers. And this mentality that somehow if nurses advance, then someone else, oftentimes it's physicians, but not only physicians, that they lose. And that was really in some ways surprising to me. Not that I didn't know that tension was there, but I was able to touch it almost instantaneously. I bumped into it like a brick wall that hit me out of nowhere.
Like a 2x4 to the forehead,
right? 2x4. And it really made me stop and say, wait a minute, I got to readjust this message because this is not about winners and losers. We need everyone. I want to be clear about this. It's the clinical workforce, the largest being nurses, but we need physicians, we need physician assistants, pharmacists, physical therapists, occupational therapists, social workers, but we also need the non-traditional clinicians, for lack of a better word, the ones that we don't think of that are also essential to really ensuring that we have the right workforce. And so this includes people with lived experience, people with behavioral health expertise, addiction expertise, community health workers. We need all of us together. And so I think the first thing that I learned in this early sort of tenure that I've had here in DC is that if I'm going to be successful, I got to keep the focus on really what the mission is and the vision, redesigning health so that we all can collectively as a nation go forward with a more optimistic and sort of bright future in terms of our well-being. It's about the belief that we can transform health and that nurses have some solutions that can be effective. And so I'm meeting with all sorts of people, both at HHS, but also CMS, CMMI, with foundations, with payers, with elected officials. I've been taking a ton of meetings and trying to articulate this vision that we've been talking about today, but then also listening carefully to what they prioritize and what they're saying is important from their point of view. And what I'm trying to do, Sean, is build communities of common purpose and goals, because we're not going to completely agree, but are there areas where we might come together in order to achieve something that has meaning for as many parts of whatever that debate is as possible? One of the things that has been very effective is that I think increasingly people realize that there are inequities in who gets care and who doesn't get care, the kind of care they get, and the kind of negative outcomes that we're seeing in communities. And so part of my language has changed to saying things like, well, can we support the most effective workforce in being able to address those gaps that we see in access and quality of care? And people seem more okay with that. More
receptive. Yeah. They want to lean in as opposed to, hang on, I need to put on my coat of armor here. I also am thinking there's going to be a wide range of opinion and idea, but there is always a place where there is agreement. And I find that one of the things that's quite very broad agreement is eliminating waste, making sure that everybody is safe. And I was thinking about the Institute, who it's going to serve, who it's going to be a resource for, who it's going to be a partner to. And you've had some really interesting partnerships, one with Manat Health, another one with Deloitte. And I would love for you to share the work that you've been, I think you're going to be continuing with Deloitte Center for Health Equity, some of this work on how much we're spending on care that resulted in really bad outcomes. So can you say more about those two partnerships and in the broad context of who the Institute's going to serve, who you're going to be a resource for, who you're going to be partnering with?
Absolutely. And so, Shauna, great question. And thank you for recognizing that we've been trying to expand our partnerships and our collaborations with both the usual partners, which tend to be nursing institutions, but also bringing in these folks who typically haven't worked with organized or formal nursing groups to advance common purpose and common goals. In order to affect change, we have to pull in some of the partners that we haven't historically pulled in. And a good example of that is an organization like Deloitte, which is an accounting firm that really looks at the business aspects of healthcare. And they had been arguing that there was a lot of waste that was going into what they called bad care, care that resulted in inequities, and that was the poor management of the major chronic conditions that, as Americans in our country, that we see in the population. What was really brilliant about that work, there's a physician there by the name of Jay Bott who oversees their health equity initiatives. He was really arguing that there's a business case for prevention and health promotion. And that, Sean, immediately, it intrigued me. It made me think, hey, this is the guy who I want to learn from. This is the guy who I want to talk to and say nurses have something to contribute. And so when I contacted Jay, he was really curious about what we were thinking about and conceptualizing within nursing, because it was a perspective that could offer a solution to some of the broader issues that he was facing at Deloitte. My interaction as a nurse with Deloitte was I started to see what the actuaries were doing in terms of their calculation of what would really be a profit, what made sense to invest in, and how they were prioritizing certain kinds of healthcare delivery and certain areas to emphasize along the health continuum. Well, that was an eye-opener for me, Shauna, because it meant that Deloitte, to really make an argument of the business model for prevention and health promotion, and to pivot and shift the country's focus from acute care to health promotion and prevention.
When the actuaries ran the numbers, how much is it costing us as taxpayers for care that is delivering bad outcomes?
This is really interesting because if I remember the numbers correctly in the report, right now it was $320 or $340 billion. That's
a billion with a B.
With a B, billion right now, Shauna, that we spend on bad care. So even if we didn't innovate in terms of developing new profitable revenue streams from prevention and from health promotion, just eliminating the waste right now, because each of us is contributing $1,000 per year from our taxpayer money to bad care. And what was beautiful about the Deloitte report and was so powerful was that it showed that that number is expected to increase significantly to close to $1 trillion by 2040. And that's simply a total waste of resources that could be allocated to much better
so
things.
We have better care. Better care. I mean, all sorts of things that we could do with that.
I think the thing that was also powerful about what they were sharing was they also made a compelling case for profits focusing on much earlier disruption of chronic disease trajectories and really the whole prevention health promotion argument. And they talked about all kinds of innovations in terms of point of care diagnostics that could help people to have more personalized control of their health. And so to me, that was super exciting, because imagine a world where healthcare providers could identify much earlier, prior to someone becoming hypertensive or prior to someone developing diabetes, that they were on a trajectory towards that. And the kinds of interventions as nurses that we actually implement would disrupt that. Could that be an entirely different way of practicing that would really innovate what today we see as being the core functions of nursing and other healthcare professionals? The other example that you asked about was Manat. So Manat is a global consulting firm that really thinks about tackling these really tough issues with a particular part of the organization that I've worked with is in the health space, where they're thinking about the delivery of care and ways to innovate how we deliver care to people. And so I was thinking about the segment of the population that experiences a lot of complexity in their care. And those are individuals who are receiving public entitlements. And so the Medicaid program, which is one of our largest payers in the country, often has individuals and overall populations that are experiencing a lot of social and economic disadvantage and complex healthcare needs. So in my mind, Sean, I was thinking if we could make policy innovations and changes within Medicaid that would improve outcomes, better management of that complex care, better integration of behavioral and physical health, better sort of addressing the social determinants of health. And if we could look at it from a nurse-driven solution, and if it were successful with this population, we could say something about what we could offer as a profession to other payers and other segments that presumably should be less complicated than the folks who are in the Medicaid program. Well, that partnership with Manat helped us to really think through what are the opportunities to better leverage nurses, and if we were going to leverage nurses, where would we leverage them and what kinds of programs? And how could we expand what nurses are doing? Well, that report is something that we worked on. We just submitted a paper to Nursing Outlook that kind of lays out a series of recommendations and really speaks to what the Medicaid program should do to better leverage nurses to achieve the outcomes that we need as a country.
So here's going to be a real interesting challenge for you. One of the things that we know is so key is storytelling, is connecting the data to people's lives, taking people's lives and expanding it out into the data. And so you have a journalist in residence. How are you going to leverage that to take the wonk speak and bring it down into Main Street so that people anywhere listening to this aren't going to feel like policy is or solutions are dry and not very exciting and not just over on this operational side? How are you going to do that? That's going to be a challenge.
It's a huge challenge, Sean. And one of the things when I've listened to you, both publicly speaking live when I've had the opportunity to hear you and also on the show, you make complex issues very accessible to people and very straightforward. And I think that kind of training is what every nurse also needs to tell the story of how health matters for all of us. In terms of the Institute, we are fortunate that we have a journalist in residence. And what that individual, Joanne Keenan, is doing is really working on a set of stories that highlight the kinds of issues that we've been talking about and translating the evidence into sort of whatever the form of journalism is, whether it be radio, whether it be print, whether it be a video segment, into a form that when people listen, they see themselves and they see their communities and their loved ones, so that it's not just about those folks in D.C. that are talking about these big issues that are sort of out of touch and don't really get what it's like on the ground, so that people can hear that we care and that we're driven by our values and that we see not just these larger policy issues, but the actual individual cases and families that we're advocating for because we know that it matters to them.
One of the things that I think a lot about is, I'm very surprised that in my conversations, whether it's with the tech community, whether it's with philanthropists, academicians, with my neighbors, with my colleagues, oftentimes how they don't connect policies with the care that they're experiencing or the care that they don't get to have, why it's so important to be paying attention to those things that show up in a ballot box, the professionals who represent our professions, or the elected officials who represent us in our school boards, all of these things that they set the environment of what we're actually able to do or what we're not able to do, how much it's going to cost you, how safe it's going to be. I feel like you have an opportunity and the Institute has an opportunity to help bridge that gap, to make a stronger connection between policy and the care that you experience and the outcomes or the health that you have or that you don't have. How are you as the Institute, how are you going to help us to look at these issues through the lens of health so that our care becomes safer, more accessible, more affordable, and definitely more equitable?
That's a great question, Shauna. That's the one that I think is the center of the work. So a couple of things come to mind. First and foremost, I think we are at our core a school of nursing. And so the Institute sits within a school of nursing. And so we have to train the nursing workforce and others through interprofessional education that is driven or led by nursing faculty in the importance of being active in policy, leadership, truly contributing and participating in ways that our wisdom, our expertise, our solutions can be adopted. So first, we have some internal work with our student bodies, and I would say not just here at Hopkins, but across nursing institutions in our country and schools that are training the future workforce. We also have to have that dialogue within our national nursing organizations where we really articulate that it is our role to advocate not just for nursing education or for issues that pertain to the nursing profession, but it is our role to really stand up and advocate for our nation's health, and that nursing plays an important role in contributing to that. I would say that we've got to engage communities beyond nursing, and that means elected officials, key decision makers, national organizations, partners. If folks are listening who want to reach out and say, hey, I'm really interested in what Shauna and Vincent are talking about, please reach out to us, because we need to have like-minded individuals and organizations that can come together and help us to advance this vision for health. We need to also be a repository of the evidence, the scientific truth about what it is that works and what doesn't work. And sometimes that's going to be unpopular, Shauna. We might say things that are rooted in evidence that people aren't going to want to hear. Well, as an institute, we need to be sort of authentic and genuine and sort of adhere to the idea that solutions have to be rooted in evidence. And the last thing we've been talking about is we need to get better at telling our story, at communicating, at using every single strategy that we can to really rally the entire country into this larger movement.
I would imagine that being in a place of such great beauty and design really brings out the best in the work that you're going to do. And so I'm super excited about what you're going to be doing, the team of people that you're going to surround yourself by, the solutions that you're going to bring to our attention, the policies that that's going to inform, the body of evidence. And my hope is that whenever people are wondering, how do we improve health, that the first question that they're going to ask is, oh, we need to call Vincent and find out what the Policy Institute's position on all of this is. What do nurses think about all of that? When we get to that point, I'm going to feel like we have really achieved something very important and valuable for the health of our nation and our citizens. So thank you. Thank you so much for your leadership. Thank you for being who you are, for bringing your full self to this work, for being patient and genuine and willing to learn and willing to lead. It's a real gift that you bring to all of us, Vincent.
Thank you so much, Shauna. It was a pleasure having this time with you. And thank you for telling our story and for being a great exemplar of a nurse in leadership. Thank you.
Nurse practitioner and researcher Vincent Guilamo-Ramos is the inaugural director of the Institute for Policy Solutions at the Johns Hopkins School of Nursing in Washington, D.C., the epicenter of policy work, where he's busy building relationships, evidence, and the business case for solutions and policy that shift healthcare practice to more preventive, value-based, and whole-person care, and bringing to the forefront the essential role nurses play in shaping solutions and policies to improve health for every community and every citizen. As Vincent shared, the U.S. life expectancy disadvantage began in the 1950s and has steadily worsened over the past 5 decades. Dozens of globally diverse countries have outperformed the United States. When you look at the graphs comparing national healthcare spend, it's scary. It's crazy just how dramatic the U.S. is as an outlier. We continue to spend more and yet die younger. And we are the only country amongst our peer nations with that expensive, unhealthy trend line. It hasn't always been this way, nor does it have to be. Country-level examples abound. Experts and evidence are clear that practice, policy, and payments built on a foundation of primary care, prevention, and health promotion, emphasizing health rather than the treatment of illness, and reaching at-risk residents early and interrupting chronic illnesses makes for a healthier nation and healthier people. And as Vincent shared, nurses for decades have been at the forefront of developing models of care delivery and interventions that have addressed outcomes that matter, have reduced cost, and have had a positive impact on the health of our nation. They are the solutions we need to build and scale as a country in order to care for every person in our country. And that's what the Institute for Policy Solutions at the Johns Hopkins School of Nursing is aiming at and need help in doing at this all-hands-on-deck policy and solutions moment. For See You Now, I'm Shauna Butler. Thanks for listening.
Nurses are transforming healthcare through innovation, compassion, and leadership. And Johnson & Johnson is proud to continue its 125-year commitment to champion nurses through recognition, skill building, leadership development, and more. The American Nurses Association is dedicated to building a culture of innovation. Nurses improve the lives of patients and communities through innovative thinking, empathetic connection, scientific rigor, and sheer determination. ANA is proud to support and advocate for our nation's most valuable healthcare resource, our nurses. For more information on See You Now and to listen to any of the earlier episodes in our library, visit seeyounowpodcast.com.